Good evening, my friends, my colleagues, my professors. We are waiting for this webinar in the last 3 weeks, looking for this combination, which is, I think, the first time to have the ECC chapter, Egypt, with the American College of Cardiology, the Egyptian Society of Cardiology, and PASCAR. Myself, I was waiting for this. We make cooperation and then full preparation in the last 2 weeks with the deputy, the vice chairman of the ECC. Welcome, deputy, with us, and Professor Khalid Shokri, professor of cardiology, and the president of Egyptian Society of Cardiology, Dr. Awad Mohammed, the president of Sudan Heart Society, and Dr. Mibki, the board members of the general secretary of the PASCAR and the chairman of the African PCR. Dr. Habib Gamra is the president of the Tunisian Society for Intervention and the president of AJDA, and PAFSIC, Dr. Habib Gamra, the well-known doctor from Tunis. And then we have Professor Ahmed Al-Gendi, the head of the cath lab in Aswan Heart Center, and Dr. Basim Abdul Hamid, the professor of cardiology and the head of the cath lab in the military hospital. So we have a collection of all groups from military hospital to the Aswan Heart Center to the PASCAR to the ECC to even the universities. So I think we have a collection. Then we started to think about what's going to you. The best is to give you the ECC highlight of intervention cardiology, and then we discussed which techniques we wanted to discuss with you. Then we settled on the CTO, and the CTO will be in 2 hours with 1.5 hours for the CTO and half an hour for the top intervention cardiology highlights of the ECC. The CTO including indication by Dr. Habib Gamra and how to do indication, the contraindications, how to manage the patient, then they go the technique. Then we decided to have a techniques in 2 ways. One, integrate by Professor Ahmed Al-Gendi, and retrograde by Professor Basim. We need from you to have questions, and this be interactive. In each session, we'll have a discussant, and these discussants will collect the questions to the presenters. Thanks to Medtronic for sponsoring this webinar, and thanks for ICOM for preparation and technical support, Riham and Ahmed Jurti. Now, the deputy, can you give an introduction to this meeting? Thank you very much. You approved, and you be the deputy is a vice president and also respond for the ECC Middle East. Thank you, deputy, to join us. I need you. Can you? You are unmuting, please. We didn't hear you. Unmute, okay. Yes, okay.
There I am. Okay, thank you, Dr. Sobi. It's such a pleasure to be here with all of you. As you said, we're excited about presenting this webinar for several weeks. We've been doing a lot of work in preparation. I want to thank all of my colleagues that are here today, and we're excited to everybody. This first webinar for the Egyptian Society of chapter of ACC, as well as in conjunction with the Egyptian Society of Cardiology and PASCAR. So we want this to be interactive, so we do want a lot of questions, and thank you very much, and we're excited for the program.
Now, Dr. Khalid Shokri, the president of the, recently elected as the president of the Egyptian Society of Cardiology. Thank you, Dr. Khalid, that you accepted to be with us and to lead the webinar with me. Dr. Khalid?
I have the pleasure and the honor to share you, Dr. Muhammad Sobhi, and share Dr. Habib in this meeting, and hope to be illustrative and highly informative to the audience. And I think it will be because the speakers are is highly selected speakers. I think we will listen to good presentations, and we will share the audience in in their questions and answering all the questions in this meeting. Thanks, Dr. Mohammed Sobhi, and hope to be a good event.
Dr. Awad. Okay, thank you, Dr. Khalid. Dr. Awad? Dr. Awad Mohammed? Dr. Awad, you hear me? Dr. Awad? Do you hear me? Okay. Dr. Awad? Unmute, please. Unmute, please. Unmute. Okay.
Yeah.
Okay.
Can you hear me?
Yes. Okay.
Yeah.
Go ahead.
Yeah, I'm here. Can you?
Yes. Go ahead, please.
Very good. We're making history today. We in Africa are very excited to have the ACC venturing into Africa. We are very familiar with Africa PCR. It's about time to get the ACC, and thank you for our Egyptian colleague for introducing the ACC. We would like to welcome the Vice President of the American College of Cardiology, Dr. Professor Tabby Trial. It's an honor and pleasure to participate with you in this webinar, and it's about time to get the ACC into Africa taking an active role, because these activities are very much needed in this part of the world. We thank Mr. Mbiku and Habib for leading the interventional cardiology in Africa. But this addition of the ACC chapter, thank you, Mohammed Sobhi, for getting us involved in this. I think we are in for a treat today, where Dr. Dipti will take us through the highlights of the ACC, and then we will be treated to Jundi and his colleagues for the CTO. I would like to welcome you all and thank you for getting us involved. Thank you.
Okay, thank you all of you, and let's start to business now. Now we are waiting for Dipti to give us for next 20 minutes the highlights of top intervention trials in the last ECC 2020. Thank you. Start, Dipti. Okay.
Okay,
Can you
great.
share your screen, please?
Yes. Okay, can you see that?
Yeah, full screen.
Okay, perfect. Well, thank you so much. So what I thought we would do was start off with the ACC 2020 top interventional trial update. I want to just, let's see.
Make full screen, please. Okay.
Yeah, that's what I want to do. So that's,
down, yeah, that's okay.
There we go.
Yes.
Okay. And I have no disclosures. So I thought we would start off with the Tycho trial, which is ticagrelor with or without aspirin in acute coronary syndrome after PCI. As you know, we've had many trials now looking at sort of decreasing the amount of time that we do our dual antiplatelet therapy. And then the goal of this trial was to evaluate ticagrelor monotherapy after 3 months of dual antiplatelet therapy compared to 12 months of dual antiplatelet therapy after PCI in acute coronary syndrome. So this was a fairly large trial, randomized parallel open label study with 3,000 patients. These were followed for about 1 year. And the average age of these patients was about 61 years. They were about 21% female. 27% of these patients had diabetes. These were acute coronary syndrome patients. About 29% had unstable angina. 35% had non-STEMI. 36% had STEMI. And these were patients that were treated with the ultra-thin bioresorbable polymer sirolimus eluting stent. And really the primary outcome looked at death, myocardial infarction, stent thrombosis, stroke, and target vessel revascularization or TIMI major bleeding at 12 months. And what you saw was that if you did ticagrelor monotherapy after the 3 months of dual antiplatelet therapy, that primary outcome was 3.9% versus the usual standard therapy, which was 5.9% for the primary outcome. And then when you look specifically at major bleeding, it was 1.7% in the ticagrelor monotherapy versus 3% with the standard group therapy. So really what we're seeing here is amongst patients with acute coronary syndrome who have underwent PCI, that really, if you use this ultra thin stent platform, that monotherapy was effective at preventing net composite ischemic and really bleeding events. And so there appears to be this emerging strategy, particularly patients that are at higher risk for bleeding, to say that maybe monotherapy is what we want to look at. Interestingly, no, there hasn't been a study that looks at just aspirin alone, and that's sort of the usual question we think of. Why ticagrelor alone? Why not aspirin alone? But that's what this Tycho trial looked at. The next trial is the popular Tabby trial, and this is really antithrombotic therapy after transcatheter aortic valve implantation in patients with long-term indication for oral anticoagulation. So a majority of these patients, 96% in fact of these patients had atrial fibrillation, and a majority of these patients, 75% of them were on warfarin therapy, about 24% were on direct anticoagulant therapy. But really, we wanted to evaluate oral anticoagulation alone compared to oral anticoagulation plus clopidogrel for 3 months in these patients that have undergone Tabby. So this was 326 patients. Follow-up was about 3 months. The mean age of these patients was 81. And what they found, in the terms of the co-primary outcome, which is BARC2 bleeding, 21.7% with the oral anticoagulant and 34.6% with oral anticoagulation plus clopidogrel. If you looked at non-procedural BARC bleeding, again, 21.7% with the oral anticoagulation alone versus a higher rate with oral anticoagulation plus clopidogrel, which was 34%. So really, the conclusion was those patients undergoing TAVR who really have that long-term indication for anticoagulation, then oral anticoagulation alone was associated with decreased bleeding and procedural bleeding compared to oral anticoagulation plus clopidogrel, similar to what we've seen in sort of the coronary trials. The next trial is the Voyager PAD, and this really is vascular outcome study of aspirin along with rivaroxaban in endovascular revascularization for peripheral arterial study. So these were patients that about 6,564 patients that were followed for 28 months. 40% of these patients, by the way, were diabetic. Median age was 67 years of age. And this evaluated rivaroxaban and aspirin and compared it to placebo and aspirin in patients that had lower extremity peripheral arterial disease that undergo revascularization. And a majority of these were endovascular revascularization. And what they did was looked at the primary outcome, which was cardiovascular death, acute limb ischemia, major amputation, myocardial infarction, and stroke. And what you saw was 17.3% in the rivaroxaban aspirin group versus 19.9% if it was just aspirin alone. So again, in terms of acute limb ischemia, you had a better outcome with the rivaroxaban aspirin group than just with aspirin alone. And then in terms of bleeding, as expected, a higher bleeding with the rivaroxaban aspirin group, 5.9% versus 4.1% in the placebo and aspirin group. So really, the conclusion was that patients with lower extremity peripheral arterial disease that undergo revascularization, that the combination of rivaroxaban and aspirin was associated with decrease in reduction in cardiovascular death, limb ischemia, amputation, myocardial infarction, CVA compared to placebo or aspirin. And actually the absolute risk reduction in this trial was about 2.6%. The next was a spiral hypertension off medication pivotal study. Now this is, we had all sort of said, we were all excited years ago for renal denervation, and then we kind of lost steam. And this is now that the catheters have gotten better, they've made some technical improvements. The thought was to retest this and say, what is the efficacy of catheter-based renal denervation in the absence of antihypertensive medications? So this was a multi-center randomized, interestingly, a sham control trial. And I think that's one of the interesting pieces, is that it's a sham control trial. And it really teaches us how important sham control trials are. And what it does is it assesses the efficacy of renal denervation in the absence of antihypertensive medications. So about 331 patients that had blood pressures that were between 150 and 180, and they were randomized to renal denervation versus the sham procedure. And what they did was looked at the primary outcome, which was really the baseline adjusted blood pressure within 24 hours. And then the secondary outcome was a baseline adjusted blood pressure at 3 months. And then of course, they also looked at no major device related or procedure related safety events that could occur at 3 months. And really what we saw was, and in terms of the 24-hour systolic change in blood pressure, we noticed that there was a bigger drop in terms of the renal denervation versus if you just did a sham control, which was only 0.6 millimeters of mercury. And the same thing in terms of the 3 month, you saw a more sustained blood pressure decrease in the renal denervation group rather than the sham control group. So what they found, the conclusion was amongst patients with uncontrolled hypertension, renal denervation was associated with significant reduction in blood pressure as compared to the sham control group. And you can see that here. And so again, it started to sort of show the superiority of a catheter-based renal denervation. So I'm sure we'll see more studies with regards to this in the future. I go back, we started off this discussing the Tycho trial, but really Tycho comes in the heels of the Twilight study, which was presented last year at TCT. And so the Twilight complex study was presented by George Dangus at this virtual meeting for ACC. And really what it is an ad hoc analysis of the Twilight trial to really evaluate the safety and efficacy of the regimen of, again, ticagrelor monotherapy versus ticagrelor plus aspirin in patients who initially completed 3 months of dual antiplatelet therapy after a complex PCI. And complex is highlighted because these were patients with complex PCI. So again, this was a multi-center trial, and total patients, randomized were 2,620 patients. And these were patients that then got usual standard care after 3 months or just ticagrelor monotherapy. And what you saw here is the patients with ticagrelor, which is here, the BARC 3 or 5 bleeding, the TIMI minor or major bleeding, the gastro, all of the different definitions. What you saw was you had less bleeding if you did ticagrelor monotherapy. What about the ischemic endpoints? Obviously, that's our big concern, is that yes, we probably are not surprised about the bleeding, but what about the ischemic endpoints? And what you saw was that there wasn't a huge difference when it came down to the ischemic endpoints, and that was a big concern. So really, amongst patients who underwent complex PCI, what we found was that ticagrelor monotherapy was associated with lower clinically relevant bleeding without increasing substantially the risk of ischemic events compared to continuing the dual antiplatelet therapy. And this effect was consistent in this particular trial. And again, this harkens back to the Tycho trial, which is what similar types of findings. I'm going to end with the Onyx 1 trial. This was the Onyx 1 global trial. This was presented initially at TCT again in 2018. And I present that because I'm going to talk about the Onyx 1 clear trial, which sort of is what was presented at ACC, but it's important to understand the trial results from this Onyx 1. And this really compared the safety and efficacy of 1 month dual antiplatelet therapy following PCI with either the Resolute Onyx drug-eluting stent or compared to the BioFreedom drug-coated stent in the high bleeding risk patients. So these were patients, about almost 1,996 patients that were followed for 1 year. 51% of these patients had acute coronary syndrome. 32% had atrial fibrillation. And what they did was they randomized these patients to either 1 month of dual antiplatelet therapy. And what they did was to look at these patients in terms of the primary safety endpoint, cardiac death and MI, stent thrombosis, and they compared it. So for the Onyx, it was 17, what we saw was that with the Resolute Onyx, 17.1% versus 16.9%. So of course, it showed non-inferiority. In terms of the BARC 2 to 5 bleeding, similar 15.1% versus 13.7%. So again, the conclusions was that the Onyx Resolute implantation is non-inferior to the BioFreedom drug-coated stent platform with both 1-month dual antiplatelet therapy amongst patients undergoing PCI. And these were patients that were the high-risk bleeding patients. And really, ischemic and bleeding rates were very high in both patients, but this is a reflection of the very high risk population that they were looking at. So again, if you wanted to see how complex these patients were, all the patients had B2C lesions, about 80% of them. In terms of the average stented length, about 38 millimeters. In terms of calcified lesions, about 46% of these patients had moderate or severely calcified lesions. And when you look at this in terms of the real world patients, 53% acute coronary syndrome patients, about 33% of these patients had atrial fibrillation, 39% of them were diabetics. And really, they did use a very broad, high bleeding risk inclusion criteria. And the majority of these, almost per patient, they had at least 1.6 high bleeding risk criteria per patient. So, so these were really the complex patients. And so if you look at it, really the conclusion came down that whether you looked at the composite of the endpoint, cardiac death, MI, stent thrombosis, you know, what we found was that the Onyx drug-eluting stent was safe and effective in these highly complex patients on 1 month of dual antiplatelet therapy. So then let's move on to the Resolute, the Onyx 1 Clear trial. This was presented online at ACC 20. And this was a study done out of the United States and Japan, and about 700 patients. This was actually the pivotal trial in the United States. This was a pivotal 1-month dual antiplatelet study in the US. And again, they did the same thing, 1 month of patients of dual antiplatelet therapy, very similar type of patients in terms of high risk patients. And really, and watched what the outcomes were in these patients. And so to give you an idea of what the criteria for some of these patients were, again, when you look, these were older patients over at the age of 75. Some of them had renal failure, liver disease, thrombocytopenia. I mean, again, lots of patients with patients that maybe needed surgery coming up. So these were the ones that were included. In terms of diabetics, about 40% of them were diabetics. About 36% had previous revascularization. Again, 36% with atrial fibrillation. Almost half of the patients, 50% of them had acute coronary syndrome. Majority of them with non-STEMI and unstable angina, about 4% with STEMI patients. If you look at the lesion criteria, about moderate to severe calcification, about 50% of them had moderate to severe calcification. Again, B2C lesion classification, a fairly high percentage of those, and the total number, the stent length per patient, again, quite high. So these were patients with complex anatomy and complex medical issues. And in terms of safety and efficacy, this looked at performance goals, and what they looked at is cardiac death, MI, target lesion revascularization, and stent thrombosis. And really it beat most of the performance goals for contemporary trials for the 1 month dual antiplatelet trials. So again, they looked at, so when you look at the highly complex patients, there were no lesion or vessel limitations. About 50% of the patients were acute coronary syndrome patients, high bleeding risk patients. And what we saw was that you could do 1 month of dual antiplatelet therapy, and it was safe and effective with that. So I think that's the last trial I'm going to stop at. And I think you're seeing some emerging themes from this talk. One is this whole idea of the emerging evidence for P2Y12 inhibitor monotherapy after short duration of dual antiplatelet therapy after PCI. So multiple trials that have been looking at that, Twilight, Tycho. I mean, even this Onyx trial is sort of getting at towards the fact that we need to sort of shorten or think about the shorter dual antiplatelet therapy, particularly if we have high-risk patients. So I think you're seeing a theme sort of emerge because we're all very worried about the bleeding issues, and we're seeing more and more complex patients that have anticoagulants and all of that. So I think this is the trend that we're seeing. So I'm going to stop here and certainly happy to answer any questions.
Okay. Thank you very much, Dipti. Can you join the moderator with me? I will start the questions. Aspirin, I want your opinion about the aspirin. Aspirin is now withdrawn from the primary prevention because of different trials, even the guidelines. Then comes the secondary prevention. We have a lot of trials in the last TT, for example, Stop Tab trial, the global leader, and then now Twilight and TECO, saying that we can take one P2Y12 apart from aspirin, and this be safe for the patient after a short duration. So why you are insisting in using aspirin, even if you go with P2Y12 with for NOAC, for example, we are removing aspirin in these all trials about. So I think the aspirin now can causing bleeding, so we can choose a stent with a short duration, and we can use one P2Y12. For example, ticagrelor is in high risk anatomy and clopidogrel in low risk anatomy. So what do you think? But is it time to get out of aspirin, or it's early to say this?
Well, I mean, I think that's the obvious question, right? But we also haven't had trials where, remember, all of these trials even done had 3 months of dual antiplatelet therapy, right? Because we haven't really stopped the aspirin. So the question is, until we do some more trials, because the other question you could say is, why not stop ticagrelor, or why not aspirin? Aspirin is cheaper. And when you think about doing, you know, global reach, I mean, aspirin may be cheaper and maybe can do some of the same things. So again, I'm not saying no. I do think that we need to really think about that and push the envelope, but it would be certainly nice to see some trials to say, if we got rid of the aspirin, what happens? Who's going to do that trial?
Okay. Dr. Khalid or Dr. Awad?
Thanks, Dr. Dipti, for this illustrative presentation. About the trial for the peripheral revascularization. Yes. What you mean with revascularization? You mean BCI or surgical revascularization? And yes.
But in the trial, they did both. They had they did revascularization, but a majority of them were done endovascular. They weren't surgically revascularized.
But dual antiplatelet therapy doesn't tested in this trial. Yes.
Correct.
Yes.
Correct.
Yes.
Right.
Yeah.
Thanks.
Look, there's a question to you about is it for TECO and is it Twilight? Is Ivers guided or angio guided for Twilight and TECO? Is it Ivers guided or angiographically guided?
For which, for TICO?
For the TECO trial and for Twilight trial.
For the TECO trial, what were you asking? Whether they did what?
Ivers.
Oh, I don't know what the rate of Ivers was.
I think it's angiographically guided.
Yeah, I think they did angiographic evaluation. I don't think it was Ivers.
Can you remove the noise, please? Because
there's another question here.
Yes, Dr. Awad, yes.
There's another question from the audience. How valid is the DAPT score in every patient, especially very old patient and patient with comorbidities? That's coming from.
Well, you tell me. I mean, I'd love to hear all the moderators talk about the
DAPT score.
Yeah. How often do you use it?
So the question, Doctor, from the audience, Dr. Awad said, is DAPT score is valid for any patient? I mean, for the very old or multiple comorbidities, or not using DAPT score in all patients?
I'm not using it in all the patients. So my question to you all is, are you all using it as frequently as maybe one?
Not really. I have to subscribe to the same point of view. We're not using it for all patients. No.
Okay. Question from me regarding the renal revascularization, the renal denervation. Okay.
Yes.
Is it revisited because of, you think, the type of the caster, or do you know the physiology better than before?
I think it's both. I do. I think that the technology's gotten better. I think there's been a lot of people very interested in it. So they're understanding the physiology better. I think they're understanding the mechanism better. So I think it's several factors that have led to some improvement in the technique. The technique is improved. So I think all of that is playing a role. Now, whether that's going to pan out into something that we're going to utilize we'll see. Only time will tell us.
Also, maybe for selection of the patient in the past trials, patients was underwent denervation, selected with severe hypertension, and maybe there is persistent changes in the vascular wall. But I think in this trial, the patient selected in an earlier stage of hypertension before making a persistent damage in the vascular or changes in the vascular wall. Do you think this is maybe a cause for the positive results of this trial?
Right. I mean, these were not patients that were treated. And I mean, if you think about it, their blood pressures were 150 to 180. You're right. These were not patients on multiple drug therapies that had resistant hypertension or that they were difficult to control and were on multi-drug therapy. So conceivably, they're easier to get a response in those patients. So that may certainly be playing a role.
Thank you, Deputy. Dr. Sobhi, I have a couple of questions.
Yes, Dr. Ahmed.
Thank you, Deputy, for an excellent wrap-up. One is a quick comment on the DAP score. I think it has performed very poorly with the Scandinavian registry in particular. And the lack of validation in such a big registry obviously put everyone cast it under a lot of doubt. We do need a score that performs good on an individual level. Unfortunately, we're not there yet. Having said that, I have a couple of questions to you. With obviously Tycho, and this is coming soon after Twilight, as you mentioned, albeit focusing purely on ACS patients. How do you put it in context along with Pegasus, for instance? So on the one hand, very short dual antiplatelet therapy for 3 months, the monotherapy versus 12 months of dual antiplatelet therapy and up to 30 months on a reduced dose of ticagrelor. And it's becoming, we're getting strong signals from both sides of the story. And Pegasus, again, was in ACS patients.
Yeah, and the question is that, number one, are we, also remember the stents are changing, right? So we're using these ultra thin stents. So that may be playing a little bit of a role. I think maybe, again, going back to, are we better in terms of techniques? Or are we doing a better job of making sure that we're deploying these better? We're following up with Ivers or whatever. Are we maximizing all of that? So that, but I know that the trend is to go towards, less and less dual antiplatelet therapy because of the concerns about bleeding. So what are some of your thoughts?
I mean, I'm a bit mixed up because...
Did you say you were skeptical?
Pegasus, for instance, there was and a bit confused, in all honesty, because with Pegasus, for instance, there was a substantial portion of the patients were not, they were managed conservatively.
Right.
So we do acknowledge that ACS represents slightly prolonged with a thromboembolic risk on the long term, not just the short term. So while I do agree that improvements in the technique and the stent platforms we're using can explain that to some extent with those managed by intervention or invasively, I don't fully understand how that can go hand in hand with patients managed.
Do you think that maybe even the medical therapies change? Maybe we're also more aggressive with our medical therapy. We're using certainly moderate to high dose statin therapy, which we weren't doing regularly at that time. So in terms of the medical management, we're certainly much more aggressive too.
I think that's an excellent point. And along with substantial lifestyle changes and emphasis on that, that might be the reason why we're seeing such a difference.
Yeah, because I think in the past, we didn't really emphasize that. We didn't really emphasize, we sort of said, oh, you're fixed. And that's a different message than what we're saying now. We're saying, yes, we fixed this lesion, but you have disease that was going to be a lifelong issue. We need to make sure that you're participating in lifestyle changes and taking medications long-term.
It's a strong message we're getting about atherosclerosis being a systemic disease indeed, not just something related to blocked arteries. The second point, and that will be very quick, is with anticoagulants after TAVRs. And again, this is strongly opposing. We have a single previous trial, which was Galileo, and that was the Roxaban in patients after TAVR. And that was prematurely terminated because of increased risk of thromboembolic events, mind you, not just. So again, how do you make sense of the data together?
Again, I think that, you know, again, this trial was pretty small, right? 326 patients. I think we need more information. Now this one was specific to the patients that have atrial fibrillation. So I think this one wasn't too surprising when you think about the coronary disease patients that have AFib. We're saying that after PCI, we're not doing triple therapy anymore. We're going towards dual therapy in the long run. So this is sort of similar to that. How do you put it together with all that other stuff? I mean, I don't know, it's hard because we're talking about an anticoagulant versus antiplatelet therapy, and in TAVR, that's a whole different sort of thing. So I really don't know that I have anything more that I can add on that.
Dipti, regarding the Onyx
yes.
One Clear and Onyx Global.
Yes.
So what's the difference, you think? That's it's already in high-risk patients, high bleeding risk with complex anatomy. One of them is no lesion vessel limitation. The second, that high complex anatomy. Do you think that there's no difference, or I don't know the objective of this, each one of them?
Well, I think to me, it just adds to the body of data. I mean, the Onyx Clear was really the first US study, and it had to be the pivotal study to sort of say that 1 month. So I think that's what that study was really aimed at. But all it does is add to our body of data that we have. So each trial adds on, and we can look at, they're very similar in terms of how they were laid out, and similar in terms of what they were utilized and what they even found. But I think it just adds to the number and sort of makes us feel more comfortable that even if you were to go to a different place and redo the trial, that you're getting very similar results.
Do you think you need to have a score for high risk of bleeding, or just you put the table in front of you and say that this one or two, this patient high risk of bleeding? Because there is
I agree. I think we need to be able to assess who are the high risk patients. You know, I mean, I think it's fine to look at the trial data, but we always talk about when you apply any of these trials, how does it fit our patient, right? We always say, oh, well, so we need a better way of saying, what are those high risk? I mean, it would certainly be nice if we had some sort of score that we could plug in and say, here, you know, these are the patients.
Okay, any questions from the panelists? Okay. Okay, thank you, Dipti, very much for this wonderful lecture and interaction. I think we can move the second session. Dr. Habib is ready. Now, Dr. Habib Gamra is going to speak about the indication of CTO. Come to the CTO indication, how to manage the patient with the CTO. Okay. Sorry, before Habib speak, Dipti, I forget to say that Onyx is now has a CE mark regarding the high risk of bleeding in Europe, but not in the United States. The CE mark, okay?
Okay.
So for the high bleeding risk, we have to shorten the duration of the PTY12, and we can choose a stent which is have a shorter bleeding. This could be very important, but we need a risk score. Thank you very much. Let's go for the Habib now.
All right. Okay. Do you see my slides?
Yes.
Yeah.
Okay. Very good.
Here as well.
Okay. Thank you very much. All right. Okay. Thank you very much for the invitation. I'm really glad to be with you tonight to share with you some thoughts about indications and techniques. I would not go into the details of the technique of CTO. My colleagues will do that just after my talk. I have no disclosure for this presentation. Now, generally, and as you know, PCI of CTO is nowadays one of the most challenging procedures in the cath lab because it is technically difficult to manage. It's time intensive, complex. It's a complex procedure very often. It requires significant contrast load. It can be associated with complications. Historically, around 50%. As you will see now, the success rate is increasing in the literature, in the big the biggest registries nowadays in the United States and in Europe, Progress CTO, Open CTO, and Euro CTO, the success rate approached 90%, which is quite impressive. Now, does that mean that we should give into temptation and attempt all chronic total occlusion? That question is actually what was asked by Galassi and his team in one of the tutorials that was published a few years ago, actually. And it was concluded in their manuscript that the decision-making process of whom to undergo CTO, PCI, should pass through a rational analysis, taking into account clinical and anatomical factors and operator experience. So if it is published, a rate of 90% success rate doesn't mean that we should go ahead and attempt all CTO. There is no CTO, there is no doubt that CTO is associated with adverse outcome. And we have learned from the SCAR registry that was updated just very recently, and that registry that has included a big number of patients with known CTO patients, 70,000, more than 70,000 patients compared to the 14,000 patients with CTO. And they did look at the registry conducted from 2005 and 2012, and they have looked at the outcome up to 6 years between the two populations. And as you can see here, the difference is really striking, showing a significant difference between the population that has CTO compared to the population that had no CTO in terms of mortality. The same finding was also looked in by a number of investigators from Spain who had looked at the impact of CTO on recurrence of ventricular arrhythmia in ischemic secondary prevention and implantable cardioverter defibrillator recipients. It's called the Back to Secondary study. And the objective of the study was clinical effect of coronary CTO in patients with ischemic cardiomyopathy receiving ICD for secondary prevention. And what they have seen after 5 years of follow-up is that patients who had CTO had a high risk of ventricular arrhythmia recurrence and mortality after ICD. So clearly that population have a worse outcome. But that does not imply we should proceed with PCI for every single patient. In fact, there are a number of questions that every operator should ask before embarking in such a complex procedure. And the first question is there an appropriate indication for the procedure? And that question was answered in a very famous study that was conducted in Fu Y Hospital. I don't know if you have heard about that Chinese hospital. It's probably the largest center of cardiovascular center, actually, with more than 1,200 patients and I think 13 cath labs. They have performed more than 42 procedures between 2010 and 2013, and they have compared in that population patients who had a CTO PCI for appropriate indication versus the population with no appropriate indications. In fact, out of these 42,000 patients, 2,659 patients had a CTO procedure that was performed. 90% of those patients completed 5-year follow-up. The primary outcome of that analysis was looking at the composite endpoint of all-cause death, all MI, or hospitalization due to heart failure. And this is the chart of that registry. What they have considered an appropriate indication is patients with myocardial artery supplanted by the occluded artery, which was not viable. Occluded vessel was not responsible for the patient's symptoms. A syntax score more than 32 in patients with left main lesions, or a syntax score more than 22 in patients with 3-vessel disease. Appropriate indication was was shown in 1,800 patients and inappropriate indications in 794 patients. They have looked at the acute result. Procedural success was similar between the two groups. They have looked at the 1-month clinical follow-up, looking at all-cause death, MI, heart failure, TVR, the TLR, stent thrombosis, etc. And there was no difference at all between the two populations. They have looked at the same parameters, but 5 years later. At 5 years follow-up, however, cardiac death, all-cause death, but also MI, definite probable stent thrombosis, TVR, all these parameters were significant in favor of the patient, of the population that had appropriate indication for having a CTO-PCR. These are the curves before and after adjustment regarding death, MI, heart failure, and it shows very clearly and significantly a better outcome at 5 years in patients with appropriate indication of CTO. All-cause death, the same findings. MI, same thing. Heart failure, also the same in favor of patients who had appropriate indication for PCI CTO. The conclusion of the study was that the longest follow-up duration demonstrated that patients with an appropriate indication as defined in the present study has significantly increased risk of long-term mortality as well as MI and heart failure, and that the adverse impact of inappropriate indication on CTO-PCI did not appear in short time, that is the first month, but was shown very clearly and gradually in long-term follow-up. And it was recommended that before starting to attempt a CTO-PCI, interventionalists, they should confirm appropriate indication as the first priority, rather than considering whether this CTO lesion can be opened by my skills, especially in the hot era of CTO angioplasty. So clearly, if you are doing a CTO-PCI with an appropriate indication, you are not serving your patient, but rather you are harming your patient. First question. Now, second question. Before embarking in CTO-PCI, you should ask the question, what is the likelihood of success? And you should rely on this in a number of parameters: patient demographics, lesion characteristics, operator expertise, cath lab setting, whether you have the appropriate equipment or not, whether or not you have a more than angiography to assess the lesion and the result, etc. So it's important to have success. Why? Because patients who have success of PCI, success of CTO-PCI, they do have much better outcome. And again, it was very clearly shown in the SCAR registry. At 6 years follow-up, the curves are completely divergent in favor, of course, of patients who have successful PCI for CTO. That question was also addressed in one of the interesting manuscripts, looking at a series of patients, that's the series of Galassi, who has published the results of his series in JACC Intervention 2019 about more than 800 patients. And he has subdivided his patients in patients with left ejection fraction more than 50%, 35 to 50%, and the other group with less than 35%. And the outcome, whether these patients have successful or failed PCI. Now, looking at the predictors of MACE occurrence at follow-up in that particular population, a number of CTO-PCI. So if the patients have failed CTO-PCI, they would have an adverse outcome at long term. Now, looking at the comparison between the two groups, successful versus failed CTO, in the three groups based on ejection fraction, you can see actually that the population with an ejection fraction of 35% is the population that benefited most of PCI CTO when it was successful. And that affects mortality, but also functional class, and also improvement of left ventricular ejection fraction. So do not be afraid to do CTO PCI in patients with poor left ventricular ejection fraction, because that is the population that benefit most, actually, from the procedure. Now, angiographic predictors of poor outcome, there are the traditional predictors that all of us know: long gap, non-tapering stump, side branch occlusion, vessel tortuosity, calcification, ostial location, poor distal vessel visibility, bridge collaterals, etc. And by the way, there are a number of scores now. The most famous one is the J-CTO score, but there are a list of them. CT rector, CL score, progress CTO score, ORA score, there is the Euro CTO Castle score, and even Galassi, in one of his recent manuscripts, he also described and introduced a novel predictive score of technical failure for CT. Now, I will finish before showing two very short cases by a consensus document that was published in the US, but there is another one published in the same time in Europe. I will start with the consensus document, the American one, which has actually gave a key principles on the indication and technique of CTO. And one of them, number one, actually, the principal indication for CTO PCI is to improve symptoms. We can leave this for discussion and see if there is a that's the only criteria for performing CTO PCI. I will pass the other ones. I will go to the principle number 6. Centers and physicians performing CTO PCI should have the necessary treatment expertise and experience to optimize success and minimize and manage complications. Now, again, Galassi has led that consensus document, the European one, and I would like to stop on this recommendation. He said a direct relationship between case volume and success rate exists for CTO PCI. In fact, it has been shown that PCI a year must be performed an operator to reach a success rate more than 90%. While achieving such volumes, this might be challenging for most institutional operators. We strongly believe that centers and operators performing fewer than 30 CTO procedures annually, they should refer the CTO patients to a more experienced operator. Now, retrograde techniques should be reserved for experienced operators, i.e. these performing more than 50 per year. So a minimum of 50 retrograde procedures, 25 as second operator and 25 as first under supervision might be advised before a cardiologist becomes an independent retrograde operator. And he focused on the logistics level, where actually this involves availability to acquire dedicated material for CTO intervention. And finally, he did focus on cath lab leadership should strive to promote training, not only among CTO PCI interventionalists, but also among nurses and technicians. These are the third question that the operator should ask: what is the approximate cost of the procedure? Particularly in limited resources countries like Africa, for example, where we should really know whether the procedure is affordable or not. And we don't have African or limited resources studies coming from these countries, but I would rely on this only manuscript that I found, which is published actually last year, and it is entitled "The Cost of Percutaneous Coronary Intervention for Chronic Total CTO in Our Current Cost-Conscious Environment," and that was about the Open CTO Registry, where actually you can read that, as one would expect, given the complexity of CTO PCI, the procedures were long, that's 120 minutes, requiring an average of 3.4 guiding catheters, 10 guide wires, 5 angioplasty balloons, 2.6 stents. The cost was approximately $15,000 US. And of course, there was no comparison with the routine PCI, but roughly the cost was $5,000 more than the routine PCI. I will finish by these two cases very quickly. The first case is about a 55-year-old man who has an inferior amide with successful thrombolysis, a 55% ejection fraction, and coronary angiogram showed severe stenosis of the RCA and proximal LAD, CTO. The decision of CABG was suggested to the patient, but he did decline to go to surgery, and we have to go ahead with the PCI, where you can see here the occluded, the long occlusion of the LAD. We did inject the right coronary artery. We did know already about that lesion of the RCA. That was the reason actually we wanted to have surgery for this patient. So we started first by treating the right coronary artery by putting stent, and then we have tried working on the LAD with of course wire escalation, and then we were stuck going antegrade despite several attempts, and we have to decide to go retrograde, as you can see here. I would go really fast, and this is the final result. That was a very long, complex procedure. This is one of our cath labs. I was really having back pain at the end of the procedure. Now we counted what we have used in that complex procedure: 12 wires, 2 microcatheters, 320 ml of contrast, and 4 DAS. So that was actually quite expensive for a procedure performed in our center. 1 CTO PCI, that approximately 4 PCI. But again, I would not leave you with this message that all PCI for CTO are like this, because this is another case of a patient who have a PCI CTO for occlusion of a stent, and it was not an acute stent, but it was chronic one. And as you might see here, the occlusion was very long. We were expecting to have a very complex procedure, but the wire went through very nicely and very quickly. 1 balloon, 1 stent, and this is the final result. This is actually, I would not say the majority, but more than 50%, you would end with perhaps 1 or 2 wires, 1 or 2 balloons, and 1 stent. Now, I would finish with this algorithm for CTO. If a patient is symptomatic, then if the patient is not symptomatic, that most likely he will take, he will be offered only medical management. If the patient is symptomatic, then we have to see whether or not the patient has had vessel disease. If no, then he will get CTO PCI. If he has a complex disease, then he will ask whether he is a good surgical candidate or not. If no, then he will have CTO PCI if he will be offered age. And if there is any other reason to have surgery, then the patient will go to surgery rather than to have a CTO PCI. So in conclusion, appropriate indication for CTO PCI is essential to maximize the benefit for the patient. Success of the procedure makes a lot of difference compared to failure and impacts considerably the outcome. Patients' demographics, lesions characteristics, operator expertise, and availability of equipment materials are the 4 cornerstones of success of CTO PCI. Thank you very much for it.
Thank you, Habib, very much for this lecture there as an introduction CTO. I will start the questions. I think these are long debates about the CTO, but you didn't mention the viability and the ischemia. I mean, you have to start your CTO patient indicating there is an indication for this CTO. So he needs to have a viability study, ischemia study, I mean, dobutamine or cardiac MRI or thallium study in order to say that this will be beneficial, and if it's more than 10%, less than 10%. According to that, now we have an ischemia trial that we have, even with more than 10% medical treatment is effective. Do you think this is a crucial point for starting? Because already there is no single study showing improvement in mortality with the CTO opening. So I will start with you, then in the open discussion with the other colleagues. Habib.
Yes, I'm sorry, Mohammed, I didn't hear your question.
I'm speaking about the starting indication of CTO. In every
Yes.
CTO, you should prove that this is beneficial for the patient. You should do a viability study for this patient, particularly if the left ventricle is not contracting well. You have to do some form of ischemia viability, either technetium, thallium, or dobutamine cardiac MRI, in order to understand that this patient will benefit from this. Part of this, that there is no single study showing that there is improvement of mortality if you open the artery. It's improving the symptoms, yes.
Yeah, you're absolutely right. I mean, in theory, I would say, in theory, you should have a viability study in order to justify your decision to go ahead and have PCI. And I'm not sure, actually, we should look for a big study to show benefit. We really need thousands of patients in order to show that in such patients. And again, patients, they don't look alike. You know, if you rely on some sub-study analysis and that particular study of Galassi, for example, when he has looked at that small population, by the way, having an ejection fraction less than 35%, he have shown a benefit. But now, does that enough to justify to go ahead and do PCI for every single patient to have an ejection fraction less than 35%? I'm not really sure. So I might not be able to convince you, Mohammed, with some data, but I would say in our practice, decision-making, the clinical judgment was our actually, was our argument to do or not do such a procedure. A patient who have 40 years of age, for example, okay, and have a CTO, will really push me to do a PCI CTO compared to patients with the same anatomy at 8 years old. So, okay. So again, I cannot convince you with science tonight, but I would say that you need really to to use your clinical judgment in order to make that decision. Of course, if you have a viability, there's no question about that. Then we don't need to discuss that. The discussable cases is when you don't have that viability.
Okay.
Yeah.
Can you join us?
Yeah, there was a question from the audience.
I'm not sure, but in my environment, when I look for a viability test, I don't find it all the time. Okay. Or because the patient is active and he's young, etc. And I really find more than one reason to go ahead and give him that benefit of the doubt.
Can I ask a question that was posted by one of the audience members? How do you see the benefit of opening up CTO after the ischemia trial, which was recently published?
Yeah, can I comment on that one? Because that seems to be a recurrent trend. I mean, ischemia has taken everyone by surprise. It's good to have a $100 million trial addressing such an important topic as the value of revascularization in patients with stable coronary artery disease. But I'm not entirely sure why we're always making the distinction between stable coronary artery disease and CTOs as such. Now, obviously, the increased complexity and the increased cost is a factor, but this is where exactly you want people and centers with the proper expertise to help maintain that sort of cost effectiveness and risk-benefit ratio. Now, it's also important to remember that ischemia patients were mostly patients with mild symptoms. I mean, more than 1/3 were entirely asymptomatic. Up to 50% of those had only some attacks per month, and only a minority of 20% had, let's say, weekly or daily symptoms. So on the whole, this was a relatively symptom-wise, mildly symptomatic cohort. The second thing, left mains were not included, and all patients had an ejection fraction of more than 35%. Now, if you take those factors and apply them to the CTO cohort, now that would make perfect sense that those patients can be managed either ways. But if you get your type of patient who is symptomatic or minimal effort, whose quality of life is severely impaired, you simply need to revascularize for the benefit of improving the quality of life, albeit, and that's a big but, you have to do it somewhere where the risk-benefit ratio can be kept to a favorable balance on the whole. Now, we've never shown a mortality or survival benefit with stable coronary artery disease with PCI. So we're not expecting to see that with CTOs.
Can I come in there and can I make a comment?
Yes.
Yeah, so I think, I mean, what we're coming down to at the end of the day is there an indication beyond quality of life and symptoms? Okay, and I want to come to the first two studies that Habib showed us. My interpretation of those studies is that inappropriate CTO is harmful as opposed to appropriate CTO is beneficial. Those are two very different things. The design, clearly, it was retrospective, there were registries, but the message is that inappropriate CTO is harmful. I don't think we should interpret that as CTO PCI, where indicated is somehow beneficial. They clearly weren't control arms that were managed medically. So for those hard endpoints. The other comparator groups looked at those in whom CTO was successful versus those in whom CTO was unsuccessful. Now, most of the time CTO is unsuccessful. There's been, you know, further damage to the ventricle, troponin release, there's often complications, etc. So it's not surprising that where CTO is unsuccessful, outcomes were worse than in those in whom CTO is successful. Again, the message there is that if you fail with your CTO, whether it's patient selection, lesion selection, technique, experience, whatever it is, there is great potential to do harm. Okay, so I think that's a very different message than looking at those outcomes showing improved MI, et cetera, and saying that CTO is better. I think we need to make very clearly that distinction. And again, just to come back to where, for me, ischemia comes into an algorithm, it really says, I mean, it's not just ischemia, actually, it's multiple studies. Again, the point you made is that when you've got chronic stable angina, for whom mortality rates are very rarely more than 2 to 3% per year, it's really, really, really hard to lower those mortality and MACE rates beyond medical treatment. Okay, and that it's really going to be about quality of life and symptoms and dyspnea, that kind of thing. Age doesn't really come into it. You know, if you're young with a CTO, you're young with a CTO. Is what all the evidence is showing us. So those are my takes on the discussion.
The question from the audience regarding the quality and quantity for the CTO operators. Because, you know, Habib said that from Alfred Galasio, you have to 100 cases per year, and then if you are not doing 30, you go to experts. If you don't do retrograde, you have to make 50. He had three numbers: 100, 30, 90. Dr. Khaled Shukri, what's your opinion about the numbers, the quality, the quantity? There's a question, two questions for the audience regarding this.
100, this is for the center, not for the patient. But Galassi said that 50 is the minimum quantity for one person to do retrograde cases, and 30 for antegrade cases, CTO case. So this is at three numbers. I have a comment on the Habib. Thanks first for elegant talk from Dr. Habib, and Dr. Ahmed Gendi make the first comment. I was to ask Dr. Habib why we have to differentiate between CTO and non-CTO lesions for PCI, because in both cases we have to save the jeopardized myocardium in both CTO and non-CTO lesion. But the second comment, I think if we need to know the effect of failed CTO intervention, we have to compare the failed CTO intervention with the non-tried CTO intervention, because when we compare CTO failed CTO cases with successful CTO cases, this is not fair. This is will be for the successful, the results would be inside of the successful cases. But if we need the results of the if the non-successful trial is harmful for the patients, we need to make a comparison between the non-successful trials with the non-tried cases of CTO. This is the second comment.
The question, another questions.
Mohammed, if you allow me, I just would like to make a comment on the number of procedure per center. I don't think the message is to keep the number of 150 and all that. It's the message is more broad. It means that actually not every center should keep doing PCI CTO if they're doing only 10, for example, a year, which doesn't make that much sense. The second thing, in a big team, it doesn't make sense that every single operator should be the CTO man of the team. And you know, just a general recommendation that we need to have reference centers for CTO. And inside that, those reference centers, maybe 1 or 2 operators, no more, would be experienced. And I have to confess that in our environment, this is not easy. I mean, everyone wants to be, you know, the Tabby man, the CTO man, the verification man. So we do not accept actually to be focused on one, you know, subspecialty, I would say, or in order to have a very good expertise in that particular space. We would like to touch in everything, and this is not very good for the for the result, for the success rate.
Okay, Deputy, you continue with the questions. You have a question, I think, from the audience. Yeah.
Let's see. I think some of this was talked about. We talked about that the randomized control trials don't show any value of CTO on mortality. Okay, so it says the volume of it. Somebody made a comment. The volume of PCI procedures, quantity and contrary to quality, is very poor measure of assessing the skills and the, you know. I don't see any other.
CTO and ischemic cardiomyopathy also needs viability, as I said.
Yes.
So, yeah. So, any questions again from Dr. Awad? Dr. Awad.
I just want to touch on CTO stuff is very expensive for sub-Saharan African continents. However, we need to do this. We are gearing up to do it. My question to Habib is there any, or the Jundi, is there new technology? Are we getting towards making the procedure a little bit cheaper with the new technology? Is it going to be any cheaper than the way it is now, to be affordable to be done in countries like Sudan, Uganda, Angola? They all here with us from Africa. What do you think, Habib?
Awad, thank you for the questions. If you have a short answer to that, expertise will make it cheaper. An expert, expertise will make it cheaper. An expert will use maybe 1 or 2 wires, and an expert will use 5 wires. So, and I do not think that actually the device is coming from other countries or other big brands that you know. We don't know to name them tonight. The one who are very, very well known on wires, on balloons, on stents, are really will provide us more success. So my short answer is to have expertise, and that's what makes it cheaper.
Thank you, Dr. Awad. It's an excellent question. I mean, 2 practical things were raised. I mean, everyone wants to be the prima donna. And I think we have a few lessons to learn from our surgical colleagues here. So early on in the days, they identified that you can't be doing aortic surgeries and mitral surgeries and congenital heart disease and so forth. So you need someone who is the mitral repair guy. You need someone who specializes in complex aortic root surgery. You need someone doing the pediatric population. So I guess as we expand particularly into the structural heart disease interventions as well, you want to have those sorts of subspecialties. It's a sort of a bitter exercise, but one that we have to go through as a community, and each within his own domain. The second question, I think Dr. Habib's comment is excellent. The most expensive CTO procedure is a failed one. So it is expensive on a cost level. It is expensive on a human level from the medical point of view, not to mention having to deal with complications. So by focusing your procedures in experienced centers and experienced hands, you are getting, in lay terms, the biggest bang for your buck. The other point is, while this might not be available to have it in every single city in sub-Saharan Africa, but you definitely need your referral, your regional referral centers. One in South Sudan, one in North Sudan. It is similar to some extent to what we're trying to accomplish in Egypt. You should not have a dedicated CTO program in every single cath lab, but you definitely want to have your go-to CTO program.
Okay. Just one last point from my end about cost, because it's obviously a huge issue to us, and I welcome the comments that have been made already. And
we want your face, please, Mirko.
Oh, right, sorry.
Open the video.
Right.
Be live with us. Okay, that's good. That's great.
So the one additional comment I'd like to add is sometimes we, again, what we compare against is very important, because in reality, very often the comparator group cost-wise for a CTO procedure is actually surgery. It's not PCI. So the patients with a complex anatomy, it might be that your alternative, if you're not going to do CT or PCI, is to send this person to surgery. And I don't know in your environments, but in ours, that's a real expensive exercise. And somehow when we send our patients to surgery, we don't think about it as a very costly exercise. So if, that sometimes is the more relevant comparator group. And then comes the issue of, referral centers and perhaps even single people within a very large, a relatively large geographical area that we can all refer to, get them the volumes that are required. I think, it only makes intuitive sense that the more you do, like most things in life, the better you're going to get at it. And there's no point really in having multiple people in a relatively small geographical area all trying to be expert. Yeah, thanks.
Okay, thank you.
Make a quick point that what Dr. Gammer said was you have to choose the patients, right? So I think ultimately these are patients that are symptomatic. That's what's driving you to do something, but they really do need to be optimized in terms of medical therapy. Sometimes what we see in a lot of these centers is some of these patients are not medically optimized before they get sent. So if you're going to go, when we're talking about cost, you only want to incur that cost on those limited patients that really will benefit from that, and not, a lot more patients. So medical therapy is still going to be your cheapest option if you can maximize it truly and make sure that they're true. If they get asymptomatic with that, maybe you don't need to do anything more.
Yeah.
So we can. Yes, Habib. Okay.
Just
I can't hear you.
First of all, patients now are very much aware about their anatomy, and what they know that they have an occluded artery, they would ask actually to be opened up, and they would tell you, I need you to do that. So you have to convince them that there is no much benefit, particularly in young patients. Now, secondly, again, as I said before, the age is an important factor to push operators to do and to look for that benefit, the benefit of the doubt. So convincing someone that they have an occluded proximal LAD, and that proximal LAD might be actually opened quite easily, and then please just stick to your medications and that's it. It's not very easy to convince not only the patient, even the operators. Actually, most of them, they would say, what do I have to lose just to open it? Even if I will add few myocytes to that patient to benefit from that doubt, why don't you do it? So this is really the practice. This is the routine practice, and this is what we are facing with every day.
Habib, I think the LED is a completely different story. The LED is LED. Even the surgeon, he send the patient for surgery because of LED. So don't speak about usually CTO LED. If you fail one or twice, send the patient for surgery. But you cannot send the patient for CX or right coronary. So you have to try one-on-one or start medical treatment. So finally, from this conclusion, your talk before the cases, because you are worried about the cases now. Ahmed is preparing himself and Basil is preparing for retrograde. That should be symptomatic patient, should be indicated patients, should be medical treatment, viable area with a large area of ischemia, and the patient is not responding. You have to prepare yourself in a well-specialized centers, and you have to start a CTO program and a referral center, as Dr. Gendi said. Not all the hospital should be in hospital. You agree about this in Africa because you are in Africa now. This is a symposium for Africa. You have to start for Sudan, for example, 1 or 2 centers. For every country in South Africa, the same. And then we prepare the cases, and then you have to have a regional, maybe a regional expert or experts from Africa or from North Africa to come to you, be webinars, or be simulators. ACC, we can help. Deputy, we need this in the future to help the Africa in the CTO. Let's go for cases. Now the third session, start by Ahmed Gendi, step-by-step antegrade approach. Ahmed.
Thank you, Dr. Muhammad, and I'd like to thank you first for making this possible. I mean, it's really good to bring East, West, and South Africa together. And similarly, I have to thank Medtronic and all the panelists for the contribution, but making this possible is something really commendable. So I hope you're getting my screen now.
Yeah.
Yeah. And what I will try to do, these are my disclosures to get them out of the way. What I will try to do is cover this topic in 20 minutes, which is no easy task. I am a bit more lucky than Basim is, though. So we'll start without further ado. Now, I'm glad that Dr. Habib already covered this, because understanding the principles that we sort of believe they are now a global part of how we practice CTO interventions is fundamental. So for the sake of time, this is 101 operators from more than 40 different countries, and 3 from this country, as a matter of fact. But this just shows that over the past few years, we have come to do the procedure more or less in the same way, because at the end of the day, we want a procedure that is predictable and reproducible in an algorithmic fashion. Now, you would remember in the older days, particularly pioneers like Dr. Khaled on the panel, they would remember that we would sit through endless sessions with Japanese experts who are brilliant at what they do, but we simply couldn't understand why this step was followed by that step. So hats off to Manos and his group with the hybrid approach on the whole for trying to put this in an algorithmic and a reproducible fashion. So to start, the antegrade approach is really your bread and butter. This is what we practice on day-to-day interventions. And when it comes to CTOs, there are certain key components that are A, delivering the microcatheter to the proximal cap of the lesion, establishing what we call the base of operations. And this is where your microcatheter is going to park, and you're going to be switching wires as the case may demand. Now, it's important to understand that the base of operations is a dynamic one. It will differ through different stages of the procedure. Then you want to cross the lesion. And once you've crossed the lesion, you want to ensure that the wire is in the true lumen distally. And you want to have solutions in the likely scenario or often the encountered scenario that you are in the false lumen, and you want to exchange for a soft tip workhorse wire and remove the microcatheter, because you don't want to be delivering balloons and stents over your CP12s and Gaia thirds, and you want to stent effectively. And we start off by this anatomy. This was a colleague next door, and they were dealing with this CTO of the LED. It was CTO as determined by history, which was slightly over 6 months of symptoms. And they went, you can see the totally occluded LED, very faint retrograde collaterals from the right coronary artery. And they thought that is going to be quite easy. It is indeed a tapered course, a JCTO score of 0. And they tried with a Fielder XT, and they ended up in the subintimal space. Now, this is not uncommon to happen, even with very simple CTOs. If you fail to stick to the principles, you can fail easy, and you can create complications. So on this particular case, we go back to the steps we just discussed. You want to go for a dual injection. So having a dual injection is a must. You want to establish the base of operations. The microcatheter would give you stability. It will give you excellent control over the tip of the wire. It will prevent the wire from losing its shape, and it will allow you to exchange wires at different stages of the procedure without losing your hardly earned position. Now, to get to the base of the operations, we use a workhorse wire, because the bend you'll be using on that workhorse wire is substantially different than the one you'll be using on the CTO wire that you would want to traverse the CTO segment with. And because the wires that we use in CTOs, especially high tip loads wires, can be quite injurious. So just after doing this, that was an easy antegrade wire escalation case, just because we went back a couple of steps and established the basis. And to understand more about CTO segments, this was a landmark study by Satoru back in 2011. And he established a very important phenomenon that even with very long-standing CTOs, there seems to be microchannels that traverse the entire length of the CTO segment. We call them through and through microchannels. And those are present in more than 70% of cases. The only problem is they're tiny, sometimes they're tortuous, so addressing those or being able to traverse them completely with your regular workhorse wire can be quite challenging. And to understand more about what wire you would want to use, now obviously it's going to be difficult to address different types of wires in such a short time. I mean, some people spend their entire careers working with wires. So, but you just want to understand that you use wires according to what exactly or the task you're expecting the wire to achieve. So using a wire for a CTO with a tapered proximal cap is going to be different than the one you would want for one with a blunt proximal cap. Is going to be different than one with speckled calcification within the body of the CTO, and is obviously going to be quite different than wires you would want to use while traversing collaterals. So as a rough guide to be able to, for the sake of time, we usually go for a reasonable first choice would be a polymer jacketed, tapered, soft-tipped wire that can, in a safe way, sort of probe and explore the proximal cap, hoping for a microchannel that can traverse the entire segment. Now, if this is unable, you can upgrade to a stiffer wire. Now, if you understand the course, a stiffer wire, such as the Gaia 2nd or Gaia 3rd, if you want an even stiffer wire, where you can perfectly navigate the wire and have perfect one-to-one torque control. That would be a very reasonable option. And if you have a very short segment of severe calcification that you want to traverse with a high tip tapered wire with high penetrability, you can go for a Conquest Pro 12 or a Hornet 14. Now, if the course of the vessel is unclear, you obviously do not want to be using your highly penetrable, relatively inflexible wires such as the CP12s and Hornet 14s, and you would go for a stiff polymer jacketed wires that tend to remain within the vessel architecture, although not particularly within the true lumen. But then again, if you end up in the subintimate space, we do have solutions for that. So again, this is a very sort of broad idea about how we think of guide wires in terms of how we escalate through the procedure. Now, one important second thing is whenever we talk about antegrade wire escalation, we essentially mean it is escalation, de-escalation. So it is not a one direction where we continuously move towards higher tip loads, but we move backwards and forwards between wires with different tip loads and different penetrability according to what stage of the procedure are you at. So if the problem is a very stiff proximal cap, you can get your CP12, but once you've gotten inside the body of the CTO itself, you de-escalate into a lower tip load. Now I'm going to jump a few slides for the sake of time, but this is again just to show you how relatively complex the wire choice is, but essentially it is totally built on what part of the procedure do you want it to achieve. So one thing to keep in mind that while we are very simple in terms of what we can do with wires with our hands, we can either push or pull or rotate clockwise or counterclockwise, but we can actually make different combinations of those two maneuvers and use them in different ways and different strategies. So the first thing is using sliding, and sliding is gentle rotation with very gentle forward motion to probe those microchannels. And we usually use polymer jacketed tapered wires such as the Fielder XT family. And remember that those wires, they give you very limited tactile feedback. So visual feedback and stopping and checking where you are becomes extremely important. Now, the other way we maneuver wires is by drilling, and drilling is really controlled rotation in both directions. We limit it to less than 90 degrees to avoid creating large subintimal hematomas, which can make our life difficult. And those, again, are usually reserved for intermediate stiffness wires, such as the Gaia second or the ultimate Bros family. But those are purposeful motions when you fully understand what the anatomy is or what the course of the vessel is. Now, the third thing we utilize is penetration. This is essentially pushing with a bit of drilling, and it is done with the intention to being able to cross very calcified or stiff portions of the lesion. We tend to use those, obviously, when the vessel or the course is very clear in our minds, otherwise you risk perforation. And we use them for a dedicated and limited part of the occlusion. Once it's done its job, we prefer de-escalating to a less risky wire. Now, the Gaia family in particular, when introduced back in 2013, came up with the rotation deflection method. And the best thing to see is to understand the rotation deflection measure is to understand more about those. So if you look at the hands on the left-hand side, you can see that this is what sliding essentially is. So it's aimless. We're very keen looking at the screen, but we, at one point, once we've got it inside the proximal cap, you will see that we went from relatively rapid spinning while we're checking visually to very gentle back and forth movement of the wire within the body of the CTO segment. Now, this is the drilling motion. On the other hand, penetration, this is again a very calcified part. We have a wire going retrogradely just as a marker, and you can see the pushing with slight rotation just to be able to overcome that calcified proximal cap. Now, the Gaia family, back to the rotation deflection, comes with the added advantage of an excellent torque control, despite a lot of ugly tortuosities and hostile anatomy. And if you look on the right-hand side, that's the Gaia next, it's the next iteration of the Gaia family, you see that once the wire encounters an obstacle, what the operator does is slight withdrawal, backward withdrawal of the wire, redirection, and then advancement. So this rotation, deflection, and push and pull maneuver is very sort of specific to the Gaia family, because the wire, if you push it against resistance, it will tend to buckle and you get stuck. So what you want to do is slightly withdraw it, rotate it in a different direction, and this will allow you to carry through. Now, once you've been able to traverse the CTO segment, you want to ensure that this is in the true lumen distally. And you really have two questions to answer for at this stage. Is the wire inside the vessel architecture, and is it inside the true lumen? And while those are related, they're quite distinct. So is the wire in the vessel architecture? And we mean by the vessel architecture that it is somewhere within the adventitial boundaries of the vessel. It's not outside into the pericardium, or inside the cardiac chamber, or inside the muscle for that matters. So the way we do that is a contralateral injection, and we look for what we call the dance. The dance is when you find the wire moving simultaneously in a to and fro motion with the vessel on the hole. Now, we don't really care when we're looking at the architecture, whether it's in the true lumen or false lumen, but we just want to ensure that it has not exited the vessel altogether. And one important thing here is to check in orthogonal views, because those can be quite tricky. And the second question is whether the wire is in the true lumen or not. And again, you want to check by contralateral injections and orthogonal views. This is the simplest and first thing to do. You can check the free motion of a workhorse wire in particular, because if you're using a Pilot 200 or a Fielder XT, because of the polymer jacket, it can fly through while it's still in the subintimal space. But if you get a workhorse or a floppy wire and it flies distally, it's usually a good sign that you're in the true lumen, albeit not exactly something reliable or 100% fail-proof. Because if you've maneuvered with a stiffer wire before introducing the floppy wire or your regular workhorse wire, and you already have a large subintimal space, your floppy wire can still fly through. And you want to be extra suspicious when you find that the wire is moving extra freely. Now, this should raise suspicion about being in the pericardium or a chamber. Now, we can also utilize Ivers to double check that we're in the true lumen. You can aspirate blood from the microcatheter tip, although that can be unreliable as well if you have a large subintimal hematoma. And finally, what we used to do in the earlier days was inject via the tip of the microcatheter. We no longer recommend that because that can, in essence, enlarge a subintimal hematoma and make the case quite difficult to complete. So this is an extreme example of the dance. Now, this is in the lateral view, but in an LAO view, you would look at this wire in a marginal branch and you might be tempted to think that this is in the right coronary artery proper. Now, you can obviously see that the wire is moving completely out of sync with the RCA. And this is after repositioning the wire. Now, when you want to ensure the wire in the true lumen, you want to do that in two orthogonal views. And it can still be tricky, especially if you have poor distal filling. And because those very dense and black wires tend to have a halo around them. So it's not particularly easy. One thing we find particularly useful is where you're giving the contralateral injection is advancing the wire and see, so you have both tactile and the visual feedback about how freely it's moving. Now, this is just to show you why you shouldn't be doing tip injections. This was a tip injection with the microcatheter in the subintimal space, and we ended up destroying the vessel distally altogether. And the only way to recover this case was to push a knuckle, what we call a star technique, and re-enter into the PDA, albeit at the expense of losing a large PLA. So you don't really want to do that. Having said that, we occasionally resort to that when we're entirely unclear about the vessel course or the vessel architecture, and we're essentially doing a tip injection either to overcome severe calcification and severe resistance to further equipment progress, or when you want to delineate anatomy because of poorly understood anatomy. Very quickly with Ivers, you can see that on the left-hand side, the wire, the Ivers probe is completely in the subintimal space, and we know it's in the subintimal space because there is no vessel architecture as such. So there's a single layer adventitia, but you don't get your classic three-layered Ivers image. On the right-hand side, on the other hand, you see the Ivers probe well within the center of a body with a clear intima, which is quite diseased on this occasion. Now we can skip that again for the sake of time. So in the event you ended up in the subintimal space, we have quite a few maneuvers. And one thing that CTO interventions have helped change in or the mindset of CTO interventionists is how to utilize the subintimal space as a friend rather than a foe. So if you end up in the subintimal space, and we occasionally do that intentionally, you have a number of options. Some of them are relatively obsolete, subintimal traction and reentry, which is essentially pushing the knuckle, pushing it hard, and the knuckle will tend to jump into the true lumen at the site of a major bifurcation or at the site of severe bending or tortuosity. The only problem is if you do that in the LED, you end up losing orioceptals on diagonals and re-enter distally, which becomes pretty futile. So we don't recommend STAR except as a bailout, and usually on the right coronary artery side when you think you can sacrifice one of the two distal branches. Contra-STAR is a variation, and again, we don't use that. LAST is a limited type of STAR, and we do not recommend it really because your re-entry is based on trying to reshape the tip of your wire and re-enter distal to the CTO segment. The success rate is hardly above 35%, and it is not reproducible even in the best of hands. So this has fallen out of favor in favor of the Bridgepoint system or the crossbus Stingray, which is a very controlled way of re-entering distal to a limited subintimal track. So we go subintimal, enter the vessel distal to the CTO segment, and the Stingray sort of establishes itself in the subintimal space with its two wings, and you can re-enter in a reliable fashion, which is in good hands, north of 80% success. Now, Ivers guided re-entry is a variation of LAST, but rather than doing it blindly and depending on angio, using Ivers for live guidance. Now, this is quite technically challenging. It needs years and years of experience, but it remains a valid option, especially for very experienced operators. Now, the most recent kid on the block is antegrade fenestration reentry that was introduced by Mauro Carlino and Lorenzo Assalini a couple of years ago. And it essentially relies on a method that is similar to reverse cut, albeit with both systems coming from the antegrade route. So you have a wire in the subintimal space, you get another system in the subintimal space, expand the balloon on the second system, and the balloon is usually sized on 1-to-1 size ratio basis, vessel to balloon size ratio basis, sorry. And the concept here is this balloon inflation can create microfenestrations that will remain open for a few seconds, and you can track them with your initial wire, thus moving from the subintimal space into the true lumen. Now, the only problem with AFR is we're getting very mixed results from different operators around the world. So I'm getting a 50-50 success rate, and on the whole, it is still a limited global experience. Now, non-dissection reentry techniques is essentially parallel wire, and parallel wire, although while falling out of favor from the Western algorithm, essentially the US algorithm, it is still very much present on the Asia-Pacific algorithm, and it is still a valid option widely used in Europe and elsewhere. Might not be the best use in terms of time efficiency, but it will sort of save you a lot of hassle and cost when it comes to having to use a stingray. Now, this is an example with an LED. You can see that the first wire, that was a Gaia second, went into the subintimal space. And with parallel wiring, you're not essentially re-entering from the subintimal space. You're essentially re-entering early on and trying to traverse the CTO segment in a completely different trajectory. So you can see that the first wire is left in space. We have a second microcatheter in place, and the second wire should be a stiffer wire, because otherwise it will just follow the path of least resistance followed by the first wire. So you can see that this minor variation or deviation from the first wire is essentially what made the difference, and we're in the true lumen. Now, you want to remember to have some sort of 3D understanding in terms of what parallel wiring, and this is the best we can get from Maramutsu, is this simple diagram that shows you that while your first wire will look perfectly in the true lumen or central in the vessel in one plane, in an orthogonal plane, you will have it very eccentric and appear subintimal. Your second wire, by definition, should overlap with the first wire on this view, on the first view, that looks it's in the center of the vessel. Then you shift to the orthogonal view and find them deviating apart. So frequent checking in two orthogonal views is paramount. Now, one way to make this easier and more reproducible and give you a chance to exchange wires frequently is to use a dual lumen microcatheter and do your parallel wire technique using those. Now, once you've crossed distally into the true lumen, you want to be able to, we remove the stiff wire or the CTO dedicated wire, get a second workhorse wire and move it and use it, because you don't want to be stenting while you have your CP12 lying distally in the LED. And the way to do that is either use a wire extension, which is a bit wasting of time. It doesn't really exist in every cath lab. To a hydraulic exchange, what we call the Nanto method. And this is essentially hooking up the hub of the microcatheter to an indeflator and inflating at 20 atmospheres. The only problem with that, if you get a bit of stickiness or the wire is bent, you can lose position altogether, lose your distal wire position. Now, the way we recommend is a balloon trapping method, and by balloon tracking, we mean moving the microcatheter all the way into the shaft of your guiding catheter, and then advancing a balloon next to the microcatheter into the distal part of the guide, inflated. This way, you trap the wire, you leave it in position, you can pull your microcatheter, then deflate your balloon and remove it. And this is the most efficient way of getting a microcatheter out without losing your distal wire position. Now, importantly, once you deflate the balloon, you want to bleed the guide back, because you will have air entrapped within the system. Now, once you've done all of that, you're back to good old stenting, and a few just sort of highlights on stenting. Remember, those are pretty much ugly vessels, so you really want good support. So support both active and passive. You really want to practice that and be familiar with different support techniques. You also want to avoid overstenting distal vessels. So very often we find that those vessels tend to grow by up to 30 or 40% on control angios 3 to 6 months down the line, once you've established good antegrade flow. So we really stick to stenting the lesion and avoiding stenting what seems like a diffusely underfilled or diffusely diseased vessel. Obviously, if you use intravascular imaging, which is heavily recommended, it will guide you substantially with where exactly you want to stent. That gets us to meticulous stent technique. We've talked about imaging and the importance of sizing. You also want to prepare those lesions quite well, and you want to aim for a good stent outcome in terms of guarding against stent failure. And the best way to do that is achieve good stent expansion. Now, a final thought before taking you through something to wrap this all up is planning. If you do not plan CTO, these are not ad hoc procedures. You want to spend your good 15 to 20 minutes of planning with the entire team. You want to avoid getting stuck in failure mode. We are very patient when it comes to CTO. We are very persistent, when it comes to CTO interventions, but that does not necessarily mean we're patient. You want to think hybrid, and by hybrid, you have all tools. So you're moving from antegrade wire escalation to ADR to retrograde, back and forth repeatedly within the same procedure, aiming for both time efficiency and safety. You want to know when to start. So knowing your JCTO score or progress CTO score is important. It's not just for putting a label on the anatomy, but it's also to guide you whether this type of patient and type of anatomy is suited for you, especially during your early learning curve. You also want to know when to call for help, and accordingly, you really want to have someone around who can be called for help. Now, successful wiring leads to a successful procedure in more than 85% of cases. So you really want to ensure if you are unable to cross with the wire into the distal true lumen, you are doomed to fail, obviously. And one final thought is you don't want to take shortcuts. This is the easiest way either to ruin a very simple case or make it unnecessarily complicated and long. And I just want to take you very quickly how we put this all together with a case example, a 60-year-old patient, smoker, hypertensive, pre-diabetic, angina, mild exertion, normal echo, no leg gadolinium enhancement. And you get this totally occluded LED, a short segment. The main technical difficulty here is the ambiguous proximal cap at the bifurcation with the medium-sized diagonal branch. And we don't have the time to go through that, but because of the unclear or the ambiguous proximal cap, antegrade wire escalation will not prove to be easy. One way to resolve to this or remove this ambiguity is Ivers guidance. We tried to do that, ended up with the wire in the subintimal space. And the next thing you want to do is try with the dual lumen microcatheter parallel wiring. That didn't work. We went for septal to septal collaterals, tried to go retrograde through the ipsilateral collaterals. That didn't work because of severe tortuosity at the septum. And we ended up using a stingray balloon. And this is your stingray balloon sitting comfortably in the subintimal space. And we do a stick, and this is the stick is using a tapered penetrative wire, a CP12 on this occasion. Then we remove it once we've created the connection between the subintimal space and true lumen, and we swapped it for a pilot 200, which flies into the true lumen distally. And this is one and also almost 90 minutes. We finished the CTO, tried 3 different approaches, dealt with the LED diagonal bifurcation, and ended up with a good final result. And that just emphasizes the need to be able to, the importance of being flexible and swift changing strategies during the same case, and obviously having the expertise to move from one approach to the other, because at the end of the day, know that this is what is required to achieve the good results Dr. Habib was mentioning earlier, with close to 90% success rates. So that the more difficult and more challenging the anatomy, the more likely your antegrade wire escalation methods are going to fail, and you will require dissection and reentry techniques, be it antegrade or retrograde. Thank you very much.
Thank you, Ahmed Gindi, for this wonderfully, and we can stay for a long time to speak about the antegrade. I know that's it's not. You think when I give it to you, I think that it's easier than the retrograde. I think it's the most appropriate for all the starting operators. So I think if you are managed to do a good antegrade CTO and you have doing more than 50 cases or 100 cases, you are ready now to go to the retrograde. Ahmed, can we summarize the final thoughts? I mean, can I put some points about this? In every case, you have two guidings. Okay. Number two, even if you have a dual injection, two guidings, not one guiding, one diagnostic. The second, you should do dual injection. Very important point. Three, wire escalation. Before this, planning this. It is GCT score, antegrade, so you're ready for anti-score. Number four, about the microcasters. You have a different microcaster. You have in your cath lab one or two at least, train one, either single or dual microcasters. Regarding the trapping, you said that it's very important, but you didn't mention how the pressure of the trapping balloon. It's used 2 millimeter balloon, 3 millimeter, 2.5, in 6 and 7 differs. What's the inflation pressure of the trapping balloon? You have to answer this because there is a question from the audience about this. And finally, you can shift to antegrade dissection if you failed from wire escalation. You understand, you illustrate different wires. And because if you start to do a CTO program in Africa, you should do you should have a microcatheters. You should have special wires in Africa, 2 or 3 wires. You device will Felder XT Gaia catheter, Gaia wire, Pilot 50 or 100 or 200, and you do with the hydrophilic wire. So at least 3 or 4 in the core lab. Microcatheters, trapping balloon, antegrade dissection, and finally you get the point. I'm summarizing the final thoughts of, because you are speaking to not more experts. Sometimes you need to simplify things. Can you repeat what I said? Because a lot of questions about this for the antegrade.
Yes, thank you. You're summarizing it perfectly well, probably much better than I did. Now, okay. The thing is, yes, there are certain principles. You want 2 guiding catheters for every case. It depends if you're a radialist or a femoral first. We don't make that particular thing, but remember with CTOs in particular, bigger is better. So you would want at least one of those to be a 7 French guiding catheter. So if you're using a sheathless radial system, that's fine. My suggestion, especially for those early on in the learning curve in CTOs, try to cut your challenges. So go for dual, bilateral femoral, 7 French guidings on both sides. Obviously, if you have the donor vessel is a small RCA, you want to be careful with your AL1s. Now, the second thing is whether the only time where we don't do dual injections is when you have 0 retrograde filling and you have ipsilateral collaterals as the main source of retrograde filling. So this is an occasion where a single guiding catheter can be allowed. You want to have your microcatheters. Now you would want to have, I would say, 2 microcatheters to start with. One of them is a low profile, let's say fine cross or caravel. One of them is a larger, stiffer microcatheter that can take you through particularly tough regions and work through the antegrade route. So your Corsairs, your Mambas, your Turnpike, those are all excellent microcatheters. And there are obviously dozens of different microcatheters, but this would suffice early on with your cases. The wires, you would want to start with 7 wires. Your workhorse wire, your tapered, soft, or low tip load polymer jacketed wire, that your XT or XTA or XTR. So XT or XTA, that would do it for now. You would want your stiff polymer jacketed wires. This can be your Pilot 200 or your Gladius. You want to have your dedicated CTO wire, and this would be the Gaia family. You want to have your penetrative wires, and those would be CP12 or Hornet 14. You want to have a wire for externalization, and an RG3 would do the job just fine. And you would want particularly, specifically a Miracle 12, because that is what we use to give support for a Stingray balloon. So those are the 7 broad categories, with perhaps with the exception of Miracle 12, which you mentioned Miracle 12 as such.
Dr. Khaled, shukri.
You obviously want your collateral surfing wires as well, and that's the sign family. With your, sorry, one last question you mentioned was your trapping. It depends what guide and what are you trapping. So if it's a 6 French guiding catheter, a 2O balloon would be fine. 2, 5, 4, 7 French guiding catheter, and 3, 0 for 8 French. Particular caution is when you're trapping a Stingray over a Pilot 200 or a slippery wire in particular. Those tend to be bulky, and the slippery wires like the Pilot 200 can prove to be difficult to trap. So we tend to oversize those. And we go up to between 12 and 16 according to...
Dr. Khaled Shukri.
I can add to, first I thank Dr. Ahmed Al-Gindi for his excellent presentation. I add to Dr. Ahmed that the selection of 2 guides for every patient, of 2 patients, only when the CTO visit and the retrograde vessel in the same direction, we use only 1 guiding caster. When the parent vessel or the vessel that gives the retrograde supply to the CTO segment on the same side of the CTO segment, we can use only guiding caster like CTO in the left circumference and receiving retrograde from the LAD. In this case, we can use only guiding caster. Also, Dr. Ahmed said that we have to be sure that the distal wire distal to the CTO segment, we have to sure that it is in the true lumen through 2 orthogonal views. This is very important, and I think it is better to use the 2 orthogonal views in every advancement to the wire, because this make the injurious effect of our dissecting part of the vessel is less if you discover that the wire is outside the vessel early before you advance it more. I have a question to Dr. Ahmed. You said that the Stingray balloon and cross-pose is better than other techniques of dissection and reentry, like STAR technique. Do you have an evidence for that? For that data you mentioned?
Yes, Dr. Khaled, we don't have a head-to-head comparison as such, but these are comparing the results from the Stingray registries in general and what you get from STAR. So obviously with STAR, it's not just about the technical thing, it's about what Colombo reported 1 year after getting this technique to light, is a 50% target vessel failure rate. And this was quite alarming, and he is obviously to be highly commended for coming back 1 year after introducing the technique and saying, listen guys, this is not working. With LAST, for instance, what we've seen with very large registries is a very limited non-reproducible success rate. So I would say with the best Japanese hands who you know and you've been there repeatedly, who would spend hours and hours, it would not exceed 50% and less than 1/3 of patients in the Western Hemisphere. Now, what we're getting from different Stingray registries is a success rate that is north of 80% in good hands. So I think it's a very reproducible way and effective way of getting back into the true lumen rather than encountering the difficulties you get with a wire-based approach.
Dr. Habib Gamra.
Yeah. I just wanted to congratulate Dr. Ahmed for such an excellent presentation, nice overview on the integrated approach of CTO PCI step by step. Two short questions, Dr. Ahmed. The first one, what are the criteria for you in your practice to stop the procedure and say, let's stop today, and they will take the patient back to the cath lab in a few days? And second question, what are the indication for use for you of Ivers and CT scan, if there is any use in your experience?
Thank you. Two important questions. I think you can't really have a one-size-fits-all answer to when to stop. It is obviously very dependent on the patient, the presentation, the experience of the operator, the experience of the center, and what exactly is the mode of failure. So sometimes the reason to stop is futility. You've tried everything and it's just not working. So it becomes pointless to try over and over again. Sometimes the reason is the contrast volume. And obviously this will be highly related to the general features of the patient, the estimated GFR and so forth. Sometimes it's races to the radiation dose, and this seems to be the most fixed parameter. So if we're not making any progress after 5 grays, we start considering seriously to stop. We almost always stop after 10 grays, which is very unlikely unless we're very, very close to finishing the procedure. The last thing that would occasionally draw you to stop the procedure is patient discomfort. So one useful thing to colleagues who are early on in their experience, and this is what we've done some years ago, is we used to have an anesthetist in the room. And this would provide, I know this is very odd to have an anesthetist in the room for a coronary procedure, but we discovered early on it would really take our minds off having to deal with occasional hemodynamic problems, having to deal with patient discomfort, and focus on the technical side when you really need to build your experience and comfort. So it's variable, but it's important that part of the planning process at the beginning of every procedure is to define the stopping criteria. So before we go into the lab, we say, okay, this is 1, 2, 3, 4, and we stop in this particular patient at this specific parameter.
Adding to this, that you have in your experience at lab, you have to do measures to reduce radiation regarding the camera, the plane. Don't stay in one plane, even the cranial plane. Some modulations of the radiation procedures. 5 gray is mandatory. You have to tell you that 5 gray to stop. But as you said, that in some cases, special case when you go at the end, you can continue. Also regarding the contrast very important. The third, the question to you about the anticoagulation during the procedures. Every 1 hour, every half an hour, ECT for the patients. How do you anticoagulate your patients during the procedures?
So heparin, we aim for ACT of 300 in antegrade cases, 350 in retrograde cases. There are different ways and different techniques and strategies that labs work. Some people introduce a very small 4 French catheter just for the sake of drawing blood. What we do is we have one of our technicians who's monitoring the hemodynamics in the control room is in charge of alerting us to the timing. So he's on the mic, ACT, and that happens every 25 minutes. We do it every 30 minutes and we check.
Okay.
Now the anticoagulant of choice is heparin. Obviously, we don't use.
Ahmed, another question. Short answer, please.
Yes.
When you do this case is a retrograde case and not an antegrade case from the beginning. The second, in failure of antegrade, when you decide to bring your patient again, 6 weeks, 2 months, how do you decide? Is there any arbitrary time in the guidelines or experience that it should be within 2 months? First question, this antegrade case or retrograde case?
Three quick answers because I just remember Dr. Habib's question. Ivers, we use it in 80% of cases, CT in 10% of cases, and those are usually the ones with previous failures. We weren't like that early on. Two is what you mentioned about radiation. I just have to emphasize that because in Africa, we have a lot of young operators, and I'm seeing, including ourselves, we've been with Progress CTO, and I'm not ashamed to say that in our first 6 months, we discovered that we were in the lowest 10% in terms of how we achieved with radiation safety. But it's important to understand where you are monitored because we've continuously improved on our radiation doses, and it's quite easy to do it once you've really set your mind to it. Your question about when to go retrograde from the outset is very difficult to answer in a short period, but essentially think about it when you have an osteal occlusion, think about it when a good operator has failed antegradely previously, think about it with an ambiguous proximal cap that cannot be resolved with different techniques to resolve proximal cap ambiguity.
Okay. Dipti, do you want to add anything to this case for the antegrade?
This was a great talk and great presentation, a good discussion. I know we're falling behind time-wise, so I think maybe we should
have to go to the second. Okay. Bassem Abhamid, the last speaker and an important case. Dr. Bassem, for retrograde case, step by step, please.
My dear professors, my dear colleagues, it's my great honor to be with you today. It's an elegant topic, which is the retrograde. My dear friend Ahmed Gindi talked about the antegrade step by step, and I think now it's time for the retrograde. So we all know that the CTO crossing techniques is divided into the antegrade technique, the dissection reentry, and the retrograde technique. So what are the indications? I think Dr. Muhammad Sobhi asked when to do retrograde. When the failed antegrade approach and when hopeless antegrade approach due to unfavorable anatomy, like the ambiguous proximal cap, the diseased distal artery, the long and tortuous CTO segment. So why retrograde BCI or recanalization of CTOs has gained acceptance as necessary technique? First, CTO is present in 20 to 22% of CAP cases. Even in the recent era of increasing success rate of CTO recanalization is still 60 to 85%. So we need every technique to improve success rate. The rationale behind this approach is that the distal fibrous cap of the CTO may be weaker than the proximal fibrous cap, resulting in easier wire crossing. If we can pass guide wire through the collateral channels, we can definitely ensure that we are in a true lumen distal to the CTO. By applying the bilateral approach, we can ensure the strongest backup and or traction force, and also we can straighten any severely tortuous arteries. So the procedure of retrograde approach involves 5 key steps. The first one is the wiring of the collateral from the donor artery into the distal bed of the recipient artery. So it depends on the type of wires we can use to cross the retrograde channel. It should be slippery, lightweight, and highly trackable, like the Fielder FC, the Whisper LC, the Whisper LS, the run-through hypercoat, the Scion Blue, and Scion Black, and the Fielder XTR. So this is an example of total LED. We can see that it's an ipsilateral retrograde, so it can pass from the LCX to the OM, through the microchannels, and finally to meet the distal part of the CTO. Now we can see at the right, there is a total LED. You are using a wire from the retrograde channel of the RCA, which is the parent artery, to the distal LED, which is the recipient artery. We can see how tortuous the microchannels and the Fielder XTR succeeded to cross these tortuous, markedly tortuous microchannels. And we can see many trials were done in different projections in order to find a way to the distal LED, and finally the filter XTAR wire succeeded to cross the LED. So finding the collaterals is the first key. The second key is delivery of the over-wire device to allow the exchange of a CTO specific guide wires. So there is wires to cross the channels and wire to cross the CTO. We need to have the over-the-wire devices, which are the microcatheters, the 5x150, the Caravelle, and the Corsair 150, and we can also use the over-the-wire balloons. Here we can see the Corsair 150 traveling over the run-through hypercoat to reach the distal channel, and now it succeeded to cross the LED and it present at the distal cap of the CTO. So now we crossed the microchannel, we pushed the over-wire microcatheters, and now the main problem and the main issue is crossing the total occlusion of the CTO using a specific wires. First, the rule is escalating from light tip load tapered wires to heavy tip load wires. So we start with the Fielder XTA, which is a tapered wire, very efficient in catching invisible microchannel inside the CTO. We can shift into different wires according to the tip load regarding the Gaia first, second, or third, the Miracle 6 or 12, the Pilot 150 or 200, the Conquest 9 and Conquest Brute 12, the Crosset, the Progress, and the Brovea 12 and 15. And once we reach to the distal cap, there are 5 techniques in order to cross the CTO, which is the direct retrograde wire crossing technique, the kissing wire crossing technique, knuckle wire crossing technique, and the controlled antigrade and retrograde sub-intimal tracking, which is the cart, and finally the reverse cart. We will first see the direct retrograde wire crossing technique. We can see in this example, after crossing with the crosshair and the wire, many wires try to cross the CTO from escalating from the light to the heavy wire. Many trials to cross, and we use the Gaia third after failure of the XTA, but all failed. And finally, after several trials, the Pilot 200 finally succeeded to cross the CTO, and it's present now in the left main. So this is a single wire technique. The kissing wire crossing technique, here at this example, when the retrograde wire fails to cross the lumen of the kissing wire, here we will a kissing wire crossing technique will be tried. The retrograde wire crossed the CTO segment subintimally and failed to puncture to the proximal lumen. So using a microcatheter, introduced the antigrade wire in the direction of the retrograde wire to meet it in the distal lumen. And after crossing, sure, we should, as my dear friend said, Dr. Ahmed, we should know that we are in the true lumen. Here we inject through the lumen of the microcatheter, and this is the final result. The third technique is the knuckle wire technique. Here, after failure of the retrograde wire to reach the proximal lumen of the proximal lumen of the antigrade, so the hydrophilic wire pushed forcibly in order to create a subintimal space. After that, the antigrade wire is introduced through in the direction of the subintimal space in order to cross to return back to the true lumen. And the antigrade wire succeeded to cross the total occlusion and placed distally, followed by dilatation, and this is the final result. Now we are talking about the CART technique, the controlled antegrade and retrograde subintimal tracking. Here we push a small balloon through the retrograde wire in order to create subintimal space. So this is a balloon through the retrograde wire in order to create subintimal space. Then pushing a wire antegradely to the direction of the balloon in order to cross to the lumen and return to pass the subintimal space and go to the lumen of the RCA. So the balloon comes from the retrograde, do subintimal space, and the antegrade wire is looking for the subintimal space and cross. This is the final result. And finally, the reverse CART technique. Unlike the CART, the balloon is inflated on the subintimal antegrade guide wire to enlarge the subintimal space. And now the retrograde wire crosses in the direction to the balloon in order trying to pass in the same track of the antegrade wire and comes back. So after crossing the CTO, what's next? It's the fourth key step is dilatation. By dilating the CTO segment, either by a small retrograde balloon or to allow advance along retrograde guide wire to the lumen of the antegrade guiding catheter back outside and introduce the antegrade over the wire. I know it's very difficult in explanation. Let's see. Now we crossed the CTO with the Corsair. We are trying to catch the antegrade guiding. Several trials were done in order to catch the guiding antegradely, but we failed. Finally, run-through wire succeeded to cross inside the guiding catheter, and the Corsair followed the wire inside the guiding catheter. So what's next? We are now retrogradely inside the antegrade catheter. Now it's time of the RG3 wire, which is pushed inside. The run-through wire was withdrawn, and we pushed the RG3 wire into the antegrade catheter. Here we can see it to come back outside from the other side. This is, we can see the RG3 wire traveling in the antegrade, this wire here, and comes back from the left side cheese, and through it we can push now a balloon over the RG3 wire. Inside we can see the balloon through the antegrade wire, the RG3 wire, sorry, reaching, this is the balloon, reaching inside the LED, and now we can see the balloon, and we are withdrawing the Corsair outside, pushing the over the wire balloon. This is an over wire balloon inside the LED, distally to stop here, crossing the CTO. After that, we pull back the wire out, the RG3 wire retrogradely. We remove it from the CTO, leaving the over the wire balloon distal. It crossed the CTO and it's distal in the LED, and advancing a run-through wire over it. So we changed the retrograde technique to the antegrade technique, and now it's time for stenting using a PTCA. And this is the final result. We can see the wire which has become antegrade, and this is the retrograde wire still in place. Of course, the antegrade, the retrograde technique has the complications. Donor artery ischemia due to spasm or thrombosis, ostial dissection of the donor artery due to deep engagement of the guiding catheter, retrograde channel dissection, retrograde channel perforation, resulting in hemopericardium, cardiac tamponade in epicardial channel, intraseptal hematoma, entrapment of retrograde guide wire, and arrhythmia, including bradycardia. And finally, CTOs are common lesions. A successful CTO revascularization can provide a significant clinical benefit. The progress in the techniques and devices has resulted into increasing success rate of CTO intervention. Techniques of retrograde canalization adds to the success rate of the center in the CTO. CTO PCI can be achieved with high success rate and low complication rates in the dedicated CTO centers, and every advanced CTO PCI center should dedicate a special team for retrograde approach. And thank you.
Thank you باسم. اوكي دكتور خالد اتفضل.
تفضل دكتور محمد. Thanks Dr. Bassem for this elegant presentation. I want to open the discussion with one question about the timing of retrialing for session to do another trial for retrograde BCI. Usually, how many days you delay the patient for the next trial?
We usually wait for about 1 month because with the first trial, I think there will be dissection, and we want this dissection to heal. And even if after healing, it can create a microchannel that helps us in the second attempt. So we usually wait from about 1 month. What about Dr. Muhammad, your opinion?
It's 6 weeks. Maybe it's not definite. This is my question to Ahmed Ganji before. There's no definite answer, but actually 6 weeks. Usually, I'm afraid to take this field. Usually, I have to study the film very well and to see what is the cause of failure, because sometimes it's failure of a good operator. It's not just because of the lesion. So we have to discuss to stay. I think 6 weeks to relieve the hematoma is very, very important. There are 2 questions for you. You can also do microcaster assisted reverse card if you fail to enter into the guiding cast retrograde wire. Is it right or not?
No, we can use a lot of techniques in order, if we failed to enter inside the anti-grade guiding caster, we can also do snaring for the wires. We can use the Godzilla, push it inside the vessel inside, but to push the microcaster retrogradely, I think we failed. The wire is easier to cross inside the antigrade in comparison to the microcaster retrograde. So after crossing the wire retrograde, we can either snare it if we fail to enter inside the antigrade guide.
I want to add for this technique. Yes, one of the tricks for making the antigrade wire and retrograde wire in the same channel, you can use the orthogonal views to see the point at which both wires are very near to each other, and make the cart or the reverse cart at this segment or at this point, because if you did the cart haphazard, you may feel many times because the 2 wires are distant from each other. Maybe the antigrade wire at the side and the retrograde wire on the other side of the vessel. So you have to select the site of the vessel at which you will make the verse cart technique.
Dr. Habib.
Yeah, again, Dr. Bassem, thank you very much for this great presentation. I congratulate you. Two short questions. In your practice, what's the percentage of antegrade versus retrograde CTO PCI? And the second question, we are talking in practice in our centers. You know, we said that it's recommended to have in a good team a CTO or two CTO operators. But do you have a non-grade CTO operator versus retrograde CTO operator, or it is the same operator who is able actually who mastering the two approaches? Did you get my point? My question?
First question, I think the antegrade to the retrograde in our center about 60 to 40%, 60 in antegrade and 40 retrograde percent regarding the cases. Regarding the, we have in our center a dedicated team for the CTO. Of course, as you said before, according to the experience. So some of my colleagues can do the antegrade. If they failed, we can change to a more experienced one to continue the retrograde in the next step. But all the team can do anti and retro. But we are, as it's regarding the experiences, it's a team. So the team, we have a dedicated team for CTO can do the anti and retro with the different experience in.
Habib, I will mention to you what also Ahmed Gendi can. In United States and Europe, they have what's known as the hybrid. You can shift to the hybrid. I mean, the antegrade, not all the antegrade operators can do retrograde operators. Yeah. It's completely different. But you be a second stage after antegrade one, and then you can go to retrograde. Then you have a retrograde team. So they shift. They call the retrograde team to come to hybrid because if the GTO is more than 2, maybe 3, they started antegrade, trial of antegrade, and they ask for the hybrid team. Gendi, do you have an idea about the hybrid team? I know that to shift or you need more than one operator.
So this is a common theme that has been repeatedly addressed. I mean, it was perfectly acceptable to have antegrade only operators, and if they fail, they refer the case to a retrograde operator. Obviously, having those within the same team at the same time in the same room was beneficial on the whole or advisable. I honestly see that as trying to cut corners. So we are at a point in time where this is a very mature subspecialty, where this is one part of chip procedures in general. And we're now talking not only about CTO operators, but we're talking about chip operators. So it doesn't really add up that you have a CTO person who can't use a rotablator, a CTO person who is not familiar with mechanical circuitry support. And those are all intricately related fields that you will frequently encounter within the same patient. And it becomes a bit artificial to say, I'm a CTO, I'm an antegrade operator only, or I'm not a rotablator guy, because if you end up opening the vessel and not knowing how to stent it properly, it becomes counterproductive, obviously. So my way of thinking, I think we want to train fellows in particular to be hybrid operators. That means having the entire armamentarium of CTO strategies under their belt, being able to shift seamlessly within the same procedure, sort of modifying their practice to the anatomy and to the patient rather than vice versa. And in places where the expertise is not exactly there, it can be very helpful, yes, to have a more experienced operator who's not entirely designed to be the CTO person down the line to give them a hand early on. But ultimately, when you're training people, train them as a hybrid operators.
Okay, thank you, Ahmed.
I think you go back to make a very important point, because it goes back to the fact that you need to have centers with high volume, because to be able to do that and to be a hybrid operator, you have to have enough volume of cases to be able to do it both ways. And I agree with Dr. Sobhi. I mean, there are many places where there are just antegrade operators or retrograde. I mean, that doesn't make sense. I agree with you. I think the modern era to do this, you have to be able to be well versed in more than one technique. And so again, you have to have centers that do that. That's where the fellows should get trained in those centers. And that's kind of the way that we should be perpetuating the knowledge about this, is that you have to be well versed in both ways.
Okay. I think we come to the end. Can you open your videos, Dr. Pico, Dr. Habib, Dr. Aoud, to have a group picture before we're taking the end, please? Yes, okay. Now you take a group picture before we speak to the. Okay. I'd like to thank the speakers. I think we're supposed to be 2 hours and a half, but we spent 3 hours. I tell you, we started with about 270 to I think 300. Now we have 200. So I think it's 100. We finished at the end because already. But we started with a big number. The big number of the tough CTO. I'm afraid of this, but actually we succeeded. Thank you, all the speakers, the ACC. Thanks to the PASCAR, thank the Egyptian Society of Cardiology. And I promise you to have a lot of webinars with the ECC, with the Egyptian Society and PASCAR in the future. Because already this succeed, we can have a survey and take your opinion of the attendee as well. Thanks to the speaker, the chairman, and thanks to Medtronic for sponsoring this webinar, and also for ICOM, Riham, and Ahmed Mu'taz for technical support. And now, Deputy, you have any announcement what you're going to do in the future and the relationship between ECC and Africa?
Well, first of all, I want to say it was a great honor today to spend time with all of you. This was a great program, so I want to thank all of you. I want to thank Dr. Sobhi for sort of pulling us all together to put on this great program. We definitely, ACC has not forgotten Africa. We have wanted to do things with Africa for a while. I think I met Dr. Gamra, right, at the CardioAlex last year, and we talked about how to bring ACC into the, how to bring Africa into the ACC fold. I think this is at least a good starting point. Maybe we could start off with a series of webinars and start doing some work together so that we can come together, and maybe ultimately with having a goal of having an ACC Africa chapter.
Okay. Dr. Khalid Shokri?
I thank you, Dr. Muhammad, for joining this group of eminent speakers and chairman, and hope to share them in another meetings and webinars. Thank you for all, and nice evening.
Mebiko? Mute. This unmute. Yes, okay.
Yes, it's been a great inaugural meeting. I really enjoyed it. I've learned a lot. It's been wonderful listening to all of you and engaging with you. It's been a wonderful start, and long may it continue.
Okay. Dr. Aoud?
Very good. Just re-echo what my colleague has said. Very good to have ACC on board now, when we're looking forward to more collaboration, more of webinar, and thank you, Sobhi, for getting us all together, and looking forward to the next one. Thank you.
Habib Gamra.
Yeah, it was really great to be with you on this wonderful webinar that focused on a very hot topic, which is CTO. I personally have learned a lot, and I too. So thanks to ACC chapter, to ACC, and particularly ACC chapter in Egypt, and to the Egyptian Society of Cardiology, and to newly named PASCI. You know, PASCI is the name of the task force of intervention in PASCAR. Now we just name it. It's new baby, chaired by our friend Dr. Aoud Mohammed, and it's the Pan-African Association of Structure and Cardiovascular Intervention. So keep in mind, PASCI will be leading many activities in the future. Thank you very much for this.
Thank you, all of you. And I promise I will have a lot of webinars with Africa, with the ECC chapter. Thank you very much. And goodbye for a nice